Palliative Medicine from Tata Memorial Hospital. Done an MD in Palliative Medicine from Tata Hospital, Mumbai, and currently working in Bharati Hospital and Research Center, Pune. She is interested in research and palliative medicine, especially in non-oncology and pediatric patients. She has a keen interest in making palliative care assisting with the population and improving the quality of life. We are honored to have you, ma'am, today. Over to you.
Thank you for the lovely introduction. Hello, everyone. So without further ado, should we just start off with the presentation? Will you be sharing the slides?
Somebody?
I'll do.
Yeah, so that I don't have any lag.
Okay, ma'am, we'll start sharing now.
Yeah. So today we'll be covering the topic of palliative medicine in non-oncology. Am I audible clearly?
Yes.
Yes, ma'am. Yes.
Okay. So how this is different from from oncology is that it is the trajectories are very different as compared to an oncology disease trajectory per se. So basically, to just recap briefly about what palliative medicine is. So basically, we've learned that it is an approach which improves the quality of life of patients with a life-limiting illness. Now, life-limiting illness does not only limit to cancer patients. It is a vast number of other diseases which are associated with decreased lifespan of the said patient. Now, next slide, please. So initially, as we all saw, the intervention from palliative medicine side was limited to just at the end of the life of the patient and was independent of the disease modifying treatment that was ongoing. But over the period, what we've seen is that it goes hand in hand with the disease modifying treatment. And it is not a straight line as it is shown in the figure, but it is to and fro from each side. Like, so if the symptoms are more, then the input or the consultation from the palliative care team would be more as compared to the treating physicians, and vice versa. So it depends when we take a back foot, when they take a back foot. And also recently, it has now expanded to the care after death as well, which comes into bereavement period. Next slide, please. This is to show again that palliative medicine basically should go hand in hand with the disease modifying agent, which can then proceed to either end of life if the patient is no longer responding to the treatment, or into rehabilitation if he responds very well. Next slide, please. Then to briefly recap what are the competencies that we are looking at from a palliative care perspective. It's basically to be able to describe what a palliative approach of care is, then to be able to manage and to address symptoms, various symptoms, not only pain, but also fatigue, anxiety, anorexia, cachexia, or nausea, vomiting that might be associated. This should be done via a very thorough history taking, physical examination, and if needed, you should do relevant investigations as well. Next slide, please. Then again, to be able to participate in the care of a dying patient, and also to help support the family members. Then we should be able, so this encompasses being able to identify what approaching death is, what are the common signs that we see with a natural dying process, and how you would be able to prepare the patient, the family, and the caregivers when the death is near. Next slide, please. Then to address the psychosocial and the spiritual needs. So there are various screening tools that are available, which can be used to address these issues, to help them take the end of life care decisions. For example, you can help them do advanced care planning to have a proper directive in place for people going to people having chronic diseases. Next slide, please. To be able to communicate well and to always remember that it is a multidimensional suffering that the patient is going through, and that it is not just unilateral. It's always a mixture of physical, psychological, social, and spiritual suffering that the patient goes through. And last one is, next slide, please. So being able to take care of yourself as well. Next slide, please. Yeah. So being able to take care of yourself, this means that you should be self-aware that you're having burnout or that you need time for yourself just to recharge so that you can take care of the patient in a more efficient way. So next slide, please. So all these were the competencies and a brief recap of what palliative care medicine is basically. Now coming to the non-oncology part of it. So I'm sure these are the graphs that you've seen multiple times. We all hope that we get the A graph of it where we have like a sudden death and we don't suffer much, but that is more often than not possible. B would kind of represent oncology disease in the sense that there is gradual decline in health, or gradual loss of functionality over a period of time, where the disease is kind of initially responding very well to the treatment. What we are going to focus on today is the graph C part, where it is organ failure. So basically all the organs and their diseases. And as you can see, though the health is not very low, but over a period of time, the functionality is very gradually decreasing. It is not as, if I can say, sudden as in graph B. It is gradual over a period with a lot of waxing and waning in the symptoms and functionality. And if you've noticed, after every waning or after every dip in the curve, the health never returns back to its normal as it was in the previous episode. So the health is going down with each exacerbation of each episode of deterioration, and which eventually would lead to death. Graph D is basically old age or frailty, where the function has declined just due to the normal aging process. Next slide, please. So where can we fit in palliative medicine? So it's basically in all chronic organ failures, all neurodegenerative illnesses, advanced rheumatological diseases, cancer, as we all know, and even in patients who are admitted in the ICUs for a prolonged time with multi-system failures, which are not responding to the treatment. Next slide, please. So this is my question to all of you now. What are the barriers that you would face while dealing with non-oncology patients? Just one slide more, like one step ahead. Okay. So non-oncology, why do you feel that it is very difficult for the physicians or for the relatives of the patients to go through? Just one more click. Okay, so from physician's perspective first, and then we'll go to the caregivers. Emotions, you said. Anything else from a physician's perspective? We are dealing with non-oncology, sir. So I'm not sure what you mean by metastasis.
Good evening, ma'am.
Good evening.
So in cancer illness, ma'am, generally we are prepared that, everyone is prepared that we are going, like cancer has no cure,
Right.
metastasis. In non-cancer illness, it's very difficult to accept death, even if the organs are failing. We are
Right.
not prepared that one day, the system is going to shut down. So that the lack of preparedness or,
Right.
we are not thought about it or we're not prepared about it. That's why it's difficult for us to explain to them that every organ is going, because even if you're old, even in your 90s, you will not, unless it's cancer, you will feel, you will live more. I mean, it is.
Patient ठीक हो जाएगा. Like that's the
Yeah.
usual dialogue that is,
Yeah, right.
even we as doctors say कि हाँ ठीक हो जाएगी, आप tension मत लो.
Yeah,
So
and we want to keep trying also, even respiratory illness, even if the patient is getting repeated COPD patient, we just want to keep trying and trying and trying. I mean,
right.
even in heart failure patients.
Yes, excellent. Anything else you feel? So basically, yes, lack of awareness amongst the physicians that it is just for cancer and not for non-oncology. Prognostication, yes. So because of the trajectory, it's very difficult to prognosticate when the patient is finally at the end step. Yeah, so intubations and extubation, intubation basically. So cup ghar pe, okay. Period of, yeah, it is long and uncertain. Okay. Okay, so can you go on next slide? So basically, from a physician's perspective, we always want to cure. As ma'am also correctly said, that we always hope that there would be a cure and that the patient would get better. They feel that they are giving up on patients, so they do not want to do anything that would make it seem as their personal failure. Next slide. So personal failure, as I said, so giving up and personal failure. Next one. And lack of awareness. These are the more important ones. The rest of them are obviously equally important, but from as a physician, you would always want the patient to get better, even if it means doing a lot of aggressive things which might be against the wishes of the patients as well. Denial from the patients, attenders, as well as the physician. Yes, so denial is one of the major reasons why there is poorer quality of life, especially during end of life. Next slide, please. So what do you feel it is from a caregiver's perspective? What all from a caregiver or a family member you would feel are the barriers for not going for palliative care?
Ma'am, they are worried that what society may say
Yes.
if they are going for a palliative care.
Yes, that is one major hurdle. They are not ready to give up. Okay. Want to keep on going. Guilt, yes, that is very important. Anything else? ICU step is required for ill patients. Okay. Feeling of guilt, yes. Lack of understanding, yes. Acceptance, okay. Next one. So disease trajectory, again, it's a so the diagnosis of cancer, as you rightly guessed, is doom is spelled for them, right? So cancer ho gaya, so the patient or the person is going to die. Eventually the person is going to die. When that might be, we don't know, but the diagnosis itself spells out death to majority of us. So in non-oncology, what happens is ki once the treatment is started, the patient returns to a near normal. It might they might fail to realize that it is not as normal as he or she was before the episode, but near normal. So, and after every admission, they are like, "Haan, theek hai." The person is coming back to his feet, he's walking, talking, doing his daily activities. So the trajectory is very confusing. Plus, from a physician's part, they never say ki it is, it's a chronic disease. Eventually, the person is going to deteriorate. Eventually, his health is going to go down, and eventually there might come a time where you would need supports, life supports, or everything else. So that is not discussed. Like in cancer, it is already spelled in because of the diagnosis, but in other non-oncology setting, it's not. The trajectory is very confusing. So the relatives, the patients fail to realize that it is a chronic disease, that it is going to get their health down a lot, though very gradual and though not very noticeable. It is going to generally have a declining functionality associated with it. And as you've already said, they want everything to be done for their loved ones. There is feeling of guilt associated with it. Next one, please. The guilt, which is very strong, which generally spells out that I have given up on my loved ones, or I've given up on my parents, or I've given up on my sister, or whoever it is. So it's difficult to accept also. It is difficult to live with it afterwards as well. Next one. And as you correctly said, what will people say? So many of our decisions are based on the fact that what will other people think or say about us. Now coming on to the disease proper. Next slide, please. Coming on to the disease proper, so I've divided the slides into systems like central nervous, cardiovascular, respiratory, and hepatobiliary. I'm not going into the details of all the diseases because that is not what we are dealing with. I would in general point out which are the major diseases in each system, and then the most common symptoms and how we manage them. So we'll have a very open discussion. So feel free to unmute, talk, or type in the chat box. Yeah. So coming to the central nervous system, so major diseases that we are dealing with are the dementias, Parkinson's disease, brain injuries, or stroke. Next slide, please. Commonly seen symptoms particular to central nervous system would be your plagias or paresis, seizures, dystonias, dysphasias, and aphasias. Now, can anyone tell me how would you manage these symptoms, and what are the difficulties that you might have faced when you've seen a particular case which was very difficult to manage?
Dementia clients, ma'am, they'll be very aggressive.
Right.
They'll have hallucinations.
Right.
And they'll have delusions on and off. So to manage dementia clients are very difficult. So we'll start with cognitive enhancers, give counseling to the family and the client.
Right.
And the caretakers also.
Yeah, and maybe they require like a continuous long-term caretaker apart from the family members. Do you feel that they require 24 hours monitoring in such cases?
Yes, ma'am. Yes, ma'am. Because they will not be able to do the regular activities also, like passing urine or stools or eating their food also. They'll forget to swallow.
Right.
So having a long-term 24-hour caretaker is very much needed.
Right. Okay. Anything else?
Thank you, ma'am.
Yes. Anything else? Suicidal tendencies. Okay. Anything else?
Seizures, ma'am. In some patient with hypoxic ischemic encephalopathy, if they have a continuous myoclonic seizure,
then you might have to put
so
them
like
on infusions, like, completely sedate them, or, infusion, like midas or continuous infusions, basically, so that they don't have further activities. Have you had to deal with patients like that?
yes, ma'am. I dealt with 2 patients during my post-graduation. So like we put them on anesthesia medications. Then later they came out, but they were in a vegetative state, ma'am.
Right.
For 3-4 years.
So recently I had a very interesting case of a patient who was suffering from tuberous sclerosis since 30 years. So she had the disease, like the onset was around 2.5 years of age, like when she was 2.5 years of age. And the parents have been managing her very well for the past 30 years. So she's now currently 32, 33. And she's been well managed. Like there's no bed sores, nutrition wise she's good, like, so nothing of that, like, they've taken care of her very, very nicely. The only thing that has happened is that the number of seizures have increased, like the number of anti-epileptics have also increased, and she developed sudden onset breathlessness. So it was basically LRTI, and they had to intubate her for it. She's going down, like, because it was a difficult airway also, because she has kyphoscoliosis associated with it. So it was a difficult airway. They had to do it via bronchoscopy, fiber optic bronchoscopy and everything. So it was very difficult. What was the main point was that the parents were unable to accept that she has deteriorated so much that it's not going to be feasible that she might not come out of this event. So we finally had to get a psychology involved, like psychiatry department involved, and we had to do a lot of grief counseling, and it's still stuck up to whether to go further, whether to, just not escalate the treatment further. But it is very difficult for chronic neurodegenerative or neurological disorders. Yes, so long-term bedridden, so bed sores are there. Dysphagia is very difficult, especially when it comes to the option between putting in an NGT or a PEG, or how you go about it. Next slide, please. So one thing that is common for management, from a management point of view, is rehabilitation should be given to all the patients, whether it is CNS, RS, CVS, or hepatobiliary. Rehabilitative, as much as you can introduce these measures, it's very important and very helpful to the patients as well. Muscle relaxant, especially in for hypertonia or contractures. Muscle relaxants, especially baclofen, because it's centrally acting, would go a long way in helping them relieve their distress and suffering, especially pain. Analgesics, again, you use it as and when needed. Even opioids, it should not be limited only to cancer pain. Analgesics, strong opioids should be used as and when needed. Anti-epileptics, as we all said, if the seizures are continuous, if it's status epilepticus, then a continuous infusion with either an anti-epileptic, benzodiazepines, or an anesthetic agent might be necessary. So to manage it according to the severity of the epileptic episodes. Speech aids, especially in patients with brain injury or stroke, where they have aphasias, various speech aids can be used. For example, like the eye pointing ones, so they spell out the word that they want to say, or asking questions, direct questions, yes and no questions. So that's if they are able to blink or move their eyes. So move the eye once if it is a yes, twice if it's a no. So asking them direct questions, yes and no questions, can be helpful for communicating with them. Again, this requires a robust rehabilitative team. So basically, you need to have a good community support where such measures are available, and the relatives, the caretakers, can be empowered to provide that to the the patient, basically, and to manage it as a whole, to manage it as a team, not just one person doing everything. Then it kind of becomes too much for us also to manage the whole thing. So have a good team, work holistically, and provide the best care for the patient. Now, I've sort of queried in nasogastric tube plus PEG feeding. So do you have any opinion as to which would be preferred over which, or which do you prefer over the other one? Anything?
For long-term perspective, I think PEG is better as compared to nasogastric tube, because switching nasogastric tube again and again is difficult. Plus, it can cause of infection, and PEG you can continue for long time. You need to replace it, but after 4, 5, 6 months.
Yeah.
So for comfort point of view, PEG is definitely better.
Yes. And even from the aspiration point of view, so they say that PEG is better compared to nasogastric tube when it comes to aspiration pneumonia. So
yeah. Ma'am, I would like to add. So we have a center when we take care of long-term patients, especially falling under the palliative category. So I think both of it, including NG tube and PEG feed, probably for the initial couple of weeks when they're moving out of hospital and moving into a rehab setup or going home, for about 6 weeks, we're looking at seeing if NG tube can be, we can rehabilitate him probably with the speech therapy, or if the patient will have, will be able to manage it. If beyond 6 weeks it is prolonging, probably counseling the family for PEG feed or peg insertion. But again, with peg feed, what we have also seen is, ma'am, patients kind of get into, cachectic phase where they are losing more muscle mass and the peg seems to get dislodged. And for such patients, if such patients in long term are at home, that also gets sometimes difficult to handle. So it's a very, I don't know,
Yeah, so
NG peg very close by. Yeah.
very, it's debatable. Like even cost wise, if you see, NG tube would be like a much lesser costly affair than inserting a peg tube.
Yes,
Plus,
ma'am.
not all the centers would have means to put in a peg tube. Like NG tube can be, even if it gets dislodged, a local physician can put in a new one for you, like immediately.
Right.
So
Yes.
those are also things that need to be considered. Again, it depends on which one prefers over another, because what studies have shown that even if it is advanced disease or a end of life situation, people are concerned about how they look. So an NG tube is kind of image distorting compared to a peg tube. Peg is kind of hidden within the clothes. So again, that has a cosmetic benefit over nasogastric tube, which might, for us, it might be silly. Like, why do you care so much about how you look at that particular time? But it is found to be important in patients or patients' way of thinking. Another question I would like to put in is that if the patient is, let's say, nearing his end of life, would you want to put an NG tube or a peg tube for such a patient, or would you want to just forego the decision of doing a NG or a peg?
Ma'am, depending on if you're looking at imminent death, like, within 24 to 48 hours, probably based on the, our previous discussions with patients, if at all we were able to make discussions with the patients and their choice, or if they said, I don't want any tubes, or the family suggests that, tube is not something that they would have liked. Imminent condition, probably withholding such, measures is something that we can consider when we are looking at an imminent passing away.
Okay. And another question then, okay, agreed completely, in the sense that if it is imminent, if it's 12 to 24 hours, maybe even 48 hours, you would not want to make the patient suffer through the procedure of putting in an NG tube. What about IV fluids? Even if it's imminent, would you want to give IV fluids to patients, or would you want to just not go for it?
Can I tell
But
some
already
personal?
there's a
Yes, please. It's open to everyone. It's not.
Yeah. So I want to share my personal experience. Actually, my son has cerebral palsy. He's right now 17-year-old. And when he was 2-year-old, I consulted a neurophysician and he advised PEG. But we have joint family, like me, my wife, my parents, and we have a caretaker too. So we decided to not to go for PEG. And right now I am happy with my decision at that time, because my son is right now 17-year-old. Of course, he has quadriplegic cerebral palsy, and he had the issue about swallowing also. But right now he has no problem. Earlier he had some micro aspiration and recurrent respiratory tract infection. But if family can give some time, if we can patiently feed the patient, so we have to look at the patient's family and support system also before taking decision regarding PEG or NG or anything.
Yes, absolutely. Okay. So usually in regards to IV fluids, I would say that usually it is sort of a sense of doing something for the family members most of the time. Saline chal raha hai baba, at least the saline is ongoing. So, something we are doing for the patient. So what we used to do in our unit is that we would put them on a very slow infusion of either NSRL or DNS, depending on what you want to give. And ki chal raha hai, but the condition does not look good. So let's he does not have that much of time. So if you want to sit with him or her, then you want to talk to him, whatever you want, last wishes. Yeah. So you make it easier for even if it's in the hospital, so you make it easier for the relatives to be with the patient. You make those arrangements with the security team, one at a time, maybe not more than one or two at a time with the patient, but still you make it easier for them to be there with the patient, especially if it is very imminent. IV fluids versus NG versus PEG depends on the time frame that we have. So even if it is imminent and last 12 hours, let's say, slow IV fluids might sometimes be beneficial for the emotional acceptance from the family's perspective, not so much for the patient per se, but for the family. NG versus PEG, again, as you all have wonderfully said, that it depends on the wishes, preferences, and values of the patient, plus the time duration that we are looking at. So if it is more than, let's say, 2 weeks, then it's better to put in an NG or a NG, because then some sort of nutrition is going. If you're looking at months or maybe more than that, a PEG or an NG, whichever is preferred again, but then we need to put in a feeding tube, whichever it might be. Okay, next slide, please. Coming to CVS, then we are looking at heart failures, basically congenital heart disease, and finally ice and vengerization, if that ever occurs. Next slide, please. So the major symptoms that we're looking at is breathlessness, pain, chest pain or heaviness, palpitations, which is generally perceived as anxiety episodes, peripheral edema, a lot of cough, which sometimes might be expectorant or sometimes irritant, a lot of fatigue and sleep disturbances, most probably due to your palpitations and all. So coming to the managements, rehabilitative measures, as I said, wherever possible, put in those rehabilitative measures. Do you feel opioids are warranted here in the symptoms that we saw for cardiovascular? And for what symptoms would you prefer?
Yes, in
breathlessness. Yes. Anything else?
We can also consider it for sleep disturbance.
Chest pain in the engine.
Okay, and chest pain. Okay. Pulmonary edema and opioids. Would you want to give for edema per se? Maybe for the breathlessness. How does opioid work in pulmonary edema? With diuretics. Yeah, diuretics, yes. For diuretics you would give. So basically to reduce the preload on the heart. So it would, with the diuretics, I mean, so what happens is that the preload gets reduced and automatically all the symptoms would come down. Like your breathlessness would come down, your edema would reduce. So that is how diuretics would work. Along with opioids, opioids would again help reduce the preload over the heart. So the palpitations and the palpitations would also reduce to a certain extent, not much, to a certain extent, because it improves the perfusion to the heart musculature. So that's how it works. What is your thoughts on using beta blockers for a lot of palpitations in a patient with cardiac disorders?
If we give beta blocker, like it reduces the tachycardia and eventually it reduces the burden on the heart, because the diastolic phase will be decreases if patient develops tachycardia. So we give beta blocker in heart failure, to chronic heart failure.
Chronic heart failure. So it's basically a very good drug to decrease the symptom also. It has additional benefits which are there, but it is, in general, if you can't find any other reason or other cause of severe palpitations, not only in cardiovascular, I mean, even in other, let's say, other disorders, beta blockers can be thought of if there are no absolute contraindications to its use, just to reduce the symptoms as well. Oxygen support wherever necessary, but always remember that Oxygen is to be used as a medicine because it is a medicine, and it should be used only when absolutely necessary. So if the saturation is falling down, then you would go for oxygen therapy. I would, in end stage cardiac diseases, I would cap the normal saturation to 85 also, if there are no symptoms associated with the said saturation levels, because that might be the new normal for that patient. So unless the patient is very symptomatic for the drop in saturations, I would not start the patient on oxygen. But again, if the patient is getting relief with the oxygen therapy despite his saturation being more than 90, I would still give oxygen depending on what the symptom at that moment is. Digitalis and all will come into the disease directed treatment for various disorders. So those would be part of the treatment that we give for, as you said, for preserved ejection fraction and everything. Okay. Any questions regarding cardiovascular disorders per se? Okay. Next slide, please. So coming to the respiratory disorders, so we have our COPD, ILD. You have your cor pulmonare, which kind of overlaps with your CVS, but it is primarily due to the lung disorders that we are having and pulmonary embolism. Next slide. So the symptoms also kind of overlap with cardiovascular. Majorly would be breathlessness. You'll have a lot of fatigue. You will have weight loss. Hypoxic, because of chronic hypoxia, or because of hypoxia, you might have delirium episodes as well, a lot of headache. Palpitations is also a common issue. Next slide, please. So again, here non-pharmacological measures or rehabilitative measures are all equally important. Opioids, again, as we said, for pain or for breathlessness. Low molecular weight, we wherever indicated, we would give that as and when required. So, but not particularly. So here, when I said pulmonary embolism, I mean something which has already been treated but still not responding to the said treatment. So again, wherever necessary, you would not want to withhold any treatment just because the patient is, palliative in the sense. End of life becomes a different spectrum of it. At the end of life, you don't hope for much cure despite all aggressive treatment. But palliative becomes a spectrum where you give the disease-directed treatment hand in hand with symptom management. So wherever you feel that there will be improvement in the symptom of these patients with any measures which are thought to be very aggressive for palliative care, it should be given if it is in the benefit of the patient. Yeah. What about diuretics? Or have you heard of nebulization with loop diuretics like furosemide or breathlessness? Has it been helpful in patients? Have you used it, and has it been helpful for you? So basically, it was given for chronic breathlessness. So normal अपना जो furosemide injection आता है, so nebulization with that. So basically, what the stipulated theory is that it reduces the edema, which in effect helps with the breathlessness. It's a very individual response that we get with the nebulized diuretics. May help has worked wonderfully well in some patients, not so much in the others. So it's individual base management that I would think of, but it is worth trying if it's available with you. What about N-acetylcysteine? As it reduces the local edema for diuretics, for furosemide. So it reduces the local edema. That's how it works. But so again, it works in some and not in others. N-acetylcysteine basically would help you clear out your airways, in the sense that it will help loosen up the mucoid secretions that you might have and just help you get it out of the airways easily. So either as a nebulization, or you get the tablet formulation as well. So whichever, nebulization would be a better choice if there are a lot of expectorations that you have. Yeah, it's a mucolytic agent basically to help thin out the secretions. And oxygen support, again, as and when needed. It can be used as a part of the for reducing the symptoms, especially breathlessness. So oxygen support wherever required. Antipsychotics, especially if you have delirious episodes or you have a lot of hallucinations, then antipsychotics can be used. Steroids come as a part of the disease-directed treatment in majority of the cases. But even at end of life, steroids can be thought of because it will just help improve the symptom profile. What are the non-pharmacological measures for breathlessness that you know of? Anyone? Fan, yes. So handheld fan basically to
Incentive spirometry.
spirometry.
Ma'am.
Okay. Propped up, opening the windows. Okay. So improve posture. Okay. Well ventilated room. Okay.
Physiotherapy.
Chest physiotherapy. Okay. Anything else? Spirometry, respiratory exercises. Excellent. Anything else? Open air. Cool temperature, basically. So open air in the sense well ventilated room, but a cool temperature of the room. So it should not be very hot or very humid. So in that sense, okay. Suctioning, okay. Okay. Yes, I think we've covered all of them. Okay. Next slide, please. Coming to the hepatobiliary, we are looking at basically liver diseases. So liver cirrhosis, liver failure. Next slide, please. The symptoms, majority of it would be your nausea, vomiting, fatigue, weight loss, all the signs of liver failure. So you'll have your ascites, you'll have bleeding, like either hematemesis or melena. You will have your pruritus, all of them. So those are the symptoms. Rehabilitative measures, again, as I said, across the board, wherever you feel that it is necessary, you give those. What would be your antiemetic of choice in patients of, let's say, liver failure with a lot of nausea? What would you prefer? Ondansetron, okay. Perinom, okay. Metoclopramide or perinom. Anything else? And why? Why would you prefer these over the others? Prokinetic, peripherally active. Okay. Prokinetic, yes. Peripherally acting. Do you want a antiemetic which is peripherally acting, or would you prefer something which is centrally acting? Okay. To prevent
centrally acting.
Centrally acting. Why would you prefer a centrally acting antiemetic? Olanzapine, okay.
Peripherally acting might cause constipation.
No. Why would you? So we are talking about that we need a centrally acting antiemetic. Why? Uremia induced, or yeah, it'll not be uremia here. It would be haloperidol. Yes. Uremic would be in renal disorders. So I agree with you. Uremia will have central action. So basically, yes. So basically, because all the compounds that we are having, we are talking about ammonia and the rest of them, they are centrally acting. So the receptors that they will act on are inside the blood-brain barrier. So you would want something that crosses them and acts centrally. So that's what you would use. So Ondem is centrally acting. Metoclopramide again crosses the blood-brain barrier. Haloperidol or olanzapine again cross the blood-brain barrier. So that's why those would be those would have better effect compared to the peripherally acting antiemetics. What about the itching that you have associated with liver disorders? So the severe itching that the patient go through, what would be your, I've actually written it here, but what would be your first line be? I've written it here. So sertraline, basically. So that has a amazing effect on hepatic induced pruritus. So any hepatic pruritus, sertraline would have almost immediate effect. So one dose and the itching comes down from let's say 100 to almost 30%. So that's the amount of relief that they have with so again, it depends on the weight of the patient. So I would start off as low as 12.5 and go up on the dose if required. But again, it can be lesser than that also if you feel that she is too frail or he or she is too frail. So I would start off with as low as 12.5 because I think it comes in the tablet of 25. So half of that, and then that's how I start. But it depends on from patient to patient.
Dexamethasone with ondansetron also helps in some patients.
Yes, it would help. Yes. Your L-ornithine, L-aspartate would also help because it will bind all the bile salts to help it excrete out. So that will also help with your nausea as well, with your pruritus also. So your hepatic NCAF management would also help with all the symptoms. It is the first line for hepatic pruritus. For renal, it is your UVA light therapy plus local capsaicin use. So it becomes a third line for renal pruritus. So it depends on the mechanism of action as well. So it's first line in hepatic, but a third line in renal. So it depends from disease trajectory as well. High bowel wash and enemas can be given. Yes. So basically, you need the patient not to be constipated in hepatic disorders. So you would give laxatives. Laxative preferably you would give. Which one? Which one do you prefer in hepatic? Lactulose. Yeah. So basically it helps bind the ammonia and clear it out and not get it absorbed in the bloodstream. So that, and what are the measures that you would give in an hepatic failure case? Hiccups. Okay. What would you give for hiccups and what would be the reason for the hiccups here? Again, your metabolic reasons of nerve end irritation. So baclofen or even a prokinetic sometimes help with so metoclopramide or baclofen. Haloperidol also would help with your hiccups. Okay. Yeah. Sorry, I couldn't hear you, ma'am.
Yeah, will it help for itching, ma'am? Deoxycholic acid will not help, na? Like
it does. So because the soil, the bile salts will get reabsorbed, right? Like it helps in excretion. So that would help. I'm sorry, I didn't read your message. So all the measures of hepatic NCAF would help with the symptoms. So it and the symptoms include your nausea, vomiting, pruritus, and everything. So you do that. It depends, like to a certain level, it would respond to the anti-NCAF measures, but not a lot. If the liver is completely damaged, then there is not much that we can do for the icterus. Diet, again, there are researchers which say that initially it was said that you should prefer plant proteins over animal proteins in a case of hepatic failure or hepatic encephalopathy. There are certain reviews which say that it is not very important on which kind of protein it is. It basically that the patient should not go into hypoglycemia. So you should have small feeds every 2 to 3 hours. So maximum starvation, as they called it, was only for 4 hours. So beyond that, the patient should not go hungry. So you should have small frequent diets. It can include animal proteins or plant proteins. Animal proteins, they said that white meat is better or easily digested compared to red meat. So you should kind of manage it according to that. Again, it does show an improvement. It's not that it will not show an improvement, but it will not be a drastic improvement after giving all UDCA or the other measures, LOLA or rifampicin or the other measures. It will not have a very drastic effect. It would help reduce the symptoms to a manageable ones, which can be then managed via your antipsychotics or the rest of them, but not that it would completely reverse the pathology that is going on. Diaphragm, yeah. Chilled water through vials for what exactly? To ensure fluid. Why would you want to restrict the fluids? In what case would you want to restrict the fluids? You mean to say for ascites or for anything else of that sort? And ascites. Okay, so ascites and fluid restrictions would become a completely different, unless you have some renal disorder associated with it. I do not want to reduce the fluid intake in case of just purely hepatic reasons, mainly because the patient may sometimes land up with dehydration because usually they are put on some sort of diuretics for the ascites. So I would not want the patient to go into dehydration, because that would further escalate your symptoms and deteriorate the patient easily. In case of anasarca, I think you should kind of manage the input and the output. So it should be in a sync, how much you're giving in and how much he's actually removing out of the system.
To add a point here.
Yes.
Yeah, in case of hepatic patient, you have to find out the cause of ascites, okay? Whether it is predominantly due to cirrhotic portion or do you have any other, suppose a patient having cirrhosis with some renal disease, then you have to do fluid restriction, else it will increase. But if a patient is only having cirrhosis, no need of fluid restriction. What we thought, if we give more fluid, it will accumulate more. No, if we restrict the fluid in cirrhotic patient, it will cause more damage to kidney and the patient will land up into renal disease or hepatorenal syndrome. In cirrhotic patient, there is splanchnic vasodilatation. So basically all the blood flow are diverted. So in those cases, we have to keep 3 points in mind: adequate fluid intake, second, adequate diuretics, keeping in mind about the renal clearance. If a patient is either diuretic intolerant or diuretic refractory. Intolerant means if you are giving aldactone, Lasix, or any other diuretics, creatinine is increasing or sodium is decreasing, or sometimes hypokalemia also occurs. So it is termed as diuretic intolerant. And refractory means you are giving the maximum dose of diuretics, that is Lasix 160, aldactone 400, and even after that ascites is not reduced, then better to swap to the therapeutic paracentesis. But in this scenario, if we restrict fluid intake, it will cause more harm to the patient. And adequate and adequate nutrition. What we think liver patient hai to mat khilao? No. In the liver patient, we think two things: low salt diet, also keeping in mind about the hyponatremia, and second is high protein diet. Usually people says don't take high protein diet. No, albumin is low in this patient, give more protein, that will help in having hydrostatic and oncotic pressure, that will reduce ascites. Thank you.
Yes. Thank you so much. So as he said, rightly said, that these are all the measures that we need to find out. So no fluid restrictions unless there is some renal involvement. Otherwise, you should give adequate hydration because dehydration can be further deteriorating. Next slide, please. coming to the renal diseases, so basically end-stage kidney diseases, which can be due to various reasons. Next slide, please. Again, the symptom profile sort of overlaps with that of hepatic. So you have your nausea, vomiting, you have your decreased appetite, you have fatigue, decreased output. So there are signs of overload. So edema, chest pain, breathlessness, headache, increased blood pressure. You have your pruritus, you have your muscle twitches and cramps, and sleep disturbances. Next slide, please. So again, what would be the antiemetic of choices here will be? As you had said previously, because of uremia. So what would be your antiemetic of choice be here?
Centrally acting.
Again, centrally acting. So you have either your ondansetrons, 5-HT3s, or your haloperidol or olanzapines, or metoclopramide may also help. Antipruritic agents, as you already mentioned, that UVA or local capsaicin application is the first choice here. Then you have your rifampicin and which was that drug? And sertraline is the third choice. Ondansetron and rifampicin become the second choice. Laxatives, again, you would give lactulose here, and supportive measures. So what is your, so the question I have is, like, symptoms you know how to manage. The main question would be, would it be still appropriate to continue with the renal replacement therapies that you're going on, and how would you address those issues associated with renal replacement therapies? So I'm talking about either peritoneal or hemodialysis. So how would you, till what time are those acceptable? Do you want to stop them at a certain time, or do you want to continue it till the very end? What are the choices, and what are the questions that generally arise? Continue till end, okay. Continue till end or on demand, okay. How would you advise a patient that it is no longer of benefit to the patient to continue with, let's say, hemodialysis or peritoneal dialysis for that matter? Okay, depends on the quality of life. You discuss with the patient and the family. It will clinically improve. Like, so you're taking away the reasons why the patient deteriorates because of the renal replacement therapies. So clinically the patient would improve. But what are the certain criteria, I would say, or what are the certain indications where it is sort of warranted that you speak with the relatives or the patient herself or himself about the condition? Pre-cachexic or cachexic patient, okay. One. Anything else? Would if you are talking about just hemodialysis now, would the increase in the number of dialysis the patient requires warrant a talk with the relative or the patient about the deteriorating nature of the renal disease? One is cannot tolerate, or there is very minimal improvement. Okay, agreed. Increased frequency. So how would you approach such patient/relatives? Even after dialysis, the patient has cardiac ailments, so basically multiple comorbidities. Let's just put it as that, multiple comorbidities, or there is a sudden exacerbation in other ailment which has lead to need for ventilation and furthermore. Okay. Yes, same quality of life or deteriorated quality of life. Okay. But how would you approach the relative / patients? Repeated hospitalization. dyspnea even at rest after dialysis, or multiple comorbidities, low blood pressure. So then dialysis just goes out of the picture, right? Because you cannot, with low blood pressure, you won't be able to give unless you start them on inotropes. Counseling with the patient, yes. How would you say that? So many of the times the patient or the relatives themselves will come to you saying ki, you know, I come for dialysis, she is almost drowsy, comatose by the time it gets done. She goes home, she's okay for half a day, and then she deteriorates back and we have to come back to the hospital. So our day the week starts with her in the hospital and ends with her in the hospital. So there is not, why are we even giving this? That is one. The patient might be very reluctant to come to the hospital. So they would not want to do that. Then they have a lot of symptoms or troubles associated with the dialysis. Like during dialysis, there is sudden hypotension, or other things, like a lot of like they had to undergo AV fistula multiple times, or they'll have to do the dialysis catheterization multiple times, whatever. So some of the things might just be so irritating to the patients over a long period of time that they themselves might approach and say ki, no further treatment, we do not want anything further to be done. As others, as you've correctly said, there's minimal improvement, or there is increased frequency, or there is poor quality of life despite doing all the renal replacement therapies. So it again depends. So it's always good to kind of liaise with your nephrologist in the hospital. Tell them that it is good to have discussion on a regular basis, to have discussions about the chronic nature of the disease that the patient is going through, and the options that we have if this no longer seems a suitable treatment option that they have. So they kind of have at the back of their mind the realization that it is a deteriorating disease that we are having, and we might have to plan out for the further things that we need to do when the time comes. Okay, anything, next slide, please. Any questions regarding renal?
What for pruritus, what can be given, ma'am? Sorry, can you what can be given for
UVA, UVB light, UVA particularly, light therapy, phototherapy basically, and local capsaicin application. So that takes away the pruritus. That is first line. Second was dapsone, ondansetron, and rifampicin as second line, and sertraline comes in as a third line, whichever is applicable.
Thank you.
So if the patient is undergoing renal replacement therapy, the pruritus would not be so much, just because the levels are under control. Okay, so I'm not sure if you've had lecture on breathlessness in particular, but I want to touch upon this because I think it is important. It's one of the most commonest symptoms that we see after pain. So this is called as the breathing, thinking, functioning pattern of breathlessness, basically chronic breathlessness in particular. It was put forward by Spathius. So it basically gives you 3 reasons why there is either exacerbated breathlessness or increased perception of breathlessness and the distress associated with it. So one is the breathing pattern, which is ineffective in general. So it might be because of the underlying pathology, which is leading to increased respiratory rate, or use of accessory muscles, or there is hyperinflation of the lungs. Second one is the thoughts or the thinking process that is associated with it. So basically thoughts about, because they are so breathless, they feel that they are dying. There are misconceptions associated with breathlessness. Too much or excessive attention just to the sensation of breathlessness, which can be because they are isolated in sorts, or because of the affected activities of daily living. and the past experiences that are associated with the breathlessness. So all these lead to anxiety, feeling of panic, or doom and gloom. So that is the thinking pattern. And the functioning pattern is because there is reduced activities of daily living. There is isolation, as I said, and they are dependent on others to do their daily activities also. So what this again leads to is deconditioning of the muscles in the limbs and chest wall as well, which again leads to breathlessness. So all these becomes sort of a vicious cycle. So to manage breathlessness properly or adequately, what he put forward was that we should address all these points. So breathing should be addressed. So non-pharmacological measures like your handheld fan breathing techniques, thinking by either relaxation techniques or counseling, psychological counseling, anxiety management, and addressing all the concerns, and functionality by doing active rehabilitative measures like you give aids for walking or activity pacing and encourage all the physical activity so that the functionality is maintained. So it's not just the, sorry, excuse me. So it's not just the physical aspect of breathlessness that you're tackling all these three aspects. So the breathlessness is managed well. Next slide, please. I think that is the end of, okay. So coming to the end of life care, particularly in non-oncology. So majority of the time, this happens in the ICU. That's what I have noticed. Oncology would be more in wards. If in a hospital setting I'm talking about, it will be mostly in the wards, because by that time the relatives and the patient themselves have been made aware or are of the opinion that they do not want any aggressive treatment. So most of the time it's either at home or in the wards. But for non-oncology patients, what happens is that they come with a lot of symptoms and are usually shifted to the ICU, where further treatment is of no benefit, and then they are counseled regarding end of life care. So this is what generally I have observed. It might differ from place to place, but in general, it occurs in the ICU. Next slide, please. So this was the end of life care pathway that was put forward by the Indian Society of Critical Care Medicine. It's basically, what it says is that it depends on the assessment of the physician, the primary treating physician, whether it is further treatment is warranted or not. This should be then discussed with other experts in the field, come to a consensus, have an open discussion with the family members or the patient if in cognitive status. And then according to the institute's policy, you go further about withholding further care, withdrawing the current care, and going to end of life care. So next slide, please. It's a bit complicated. To put it very simply, it is either from the emergency department or from the ward or directly to the ICU. If the physician finds that there is prognostic uncertainty, and it has been in consensus with other members of the team, after discussion with the patient or the relatives, you've established what the goals of care for the patient is. Then you go for either withholding or withdrawing of life-sustaining treatment, and you give a proper comfort care or proper end-of-life care to the said patient and support the family through the process. It is important to note that you should document all the discussions that you've had with either the physicians or the relatives, and have a very to and fro discussions. Also make them understand that once the decision is made, if they change the decision, that is also okay, and that they can do that, so that if down the line they change their mind about withholding the treatment can again be restarted, though it might not be of much benefit. Next slide, please. Again, so non-oncology particularly, it's a very long road ahead that we have, because it's the general lack of awareness amongst the physicians is a lot, and to get them to accept the fact that they have palliative care needs is also cumbersome and tiring. So it's a long road ahead that we have, and let's just hope that there is increased awareness as we go ahead. Next slide, please. I think that's the end of. Thank you. Thank you so much.
Thank you, ma'am.
Any questions that we have? Or maybe we can do it with the case presentation if that's.
Yes, ma'am. I think we can go for the case presentation, and after the case presentation, we'll go for discussion.
Yes.
May I call upon Dr. Jolsna for the case presentation?
Yeah, hi, sir. Can you hear me? Am I audible?
Yes, madam, you are audible.
Okay.
Buddy, can you please share the screen? All right.
Good evening, one and all present here. Myself, my name is Dr. Jyotsna. I'm a faculty in a private medical college in Bangalore, Karnataka. So today I'm going to present a case of a 76-year-old female who was diagnosed with COPD with an acute infective exacerbation with other comorbidities such as CKD, hypertension, and Parkinson's. She presented with complaints of fever since 3 days, cough since 3 days, and breathlessness since 1 day. The 76-year-old female patient was in her usual state of health 3 days back, following which she developed fever along with cough. The cough was productive in nature, yellowish with a yellowish sputum, no blood-stained or not foul smelling. Last night she had an experience of an increased breathlessness, and it was progressive in nature. There's no other history of chest pain, palpitations, nausea, or vomiting. In the past, she has been admitted twice due to breathlessness over the past 1 year. She has been on the CPAP machine for the past 7 years. COPD was diagnosed 20 years back when the breathlessness initially started. There is history of passive smoking in the family. Her late husband, was an active smoker. She is known case of hypertension, chronic kidney disease, Parkinson's disease, for which she is on medical management. And she also has a history of filariasis in the past, of which details are unknown. On examination of the patient is conscious but drowsy. She is obese in build. Her vitals are heart rate of 92, blood pressure on the slightly higher side, 160 by 90, a respiratory rate of 35, a saturation of 74, and the temperature showing 99 degrees Fahrenheit. Edema of legs were present. There are no other features like pallor, icterus cyanosis, or clubbing. Orthopnea was very evident, and she uses hearing aids. On systemic examination, the significant findings were the use of accessory muscles of respiration, and there was an hyperresonant note in the right lower lobe, and on auscultation there was bilateral wheeze audible and decreased breath sounds in the right lower lobe, and crepitations over the left lower lobe and the right middle lobe. Other systems were CVS and parabdomen were normal. CNS, she was drowsy and she had sensorineural hearing loss. Next. So she was right away admitted into the ICU and started on oxygen therapy. She was started with 10 liters of oxygen via face mask, and she was given nebulization with bronchodilators and corticosteroids. Routine investigations were sent, and the ABG analysis showed a significant carbon dioxide retention and poor oxygenation. She was later shifted over to NIV, and and that was when her saturation picked up to 86%. Additional treatments such as cough expectorants, antibiotics were given. Her psychosocial aspects of this patient was that she's an elderly lady, nearly bedbound at home, with only living son, with her son living with her only. She is alone at home when the son is working during the day. She is unable to take care of herself, but does not accept this fact, which leads to poor hygiene and underestimation of symptoms, as she does not tell them to the son. Her condition has been deteriorating over the years, and it limits her day-to-day activities over the years, and to presently being bedbound. There have been recurring admissions, checkups, and medications that has been taking a toll on the financial status of the son. Prior admissions in the ICU has left her in a state of fear of further admissions and tries to delay and deny any advice of hospitalization. The son feels burdened, and sometimes he feels helpless with the responsibilities of taking care of his mother. So the medications given were inhalers, such as bronchodilators and corticosteroids, antipyretics for the fever control, antibiotics to treat the infection that was picked up. She was continued on her hypertensive, Parkinson's, and CKD and hypothyroid medications. Continuous NIV was initiated to keep the carbon dioxide at bay and improve oxygenation. Invasive ventilation was kept as standby. So the main concerns by the patient were the recurrent admissions due to her breathlessness. She had fear of getting admissions due to aggressive treatments, prolonged ICU stays, and battery of investigations each time of admission. The patient is in a debilitating condition with a risk of demise at any point of time. Concerns faced by the son were financial concerns and emotional concerns, as he is alone and he has no support system per se. To summarize, this is an 72-year-old elderly female who presented with fever, cough. It was progressive and associated with breathlessness. So she's a known case of COPD who's on CPAP treatment at home. She has had two such similar episodes over the past 1 year, for which she was hospitalized. And she has a prolonged history of cigarette smoke. She's financially dependent on her son. In the hospital, she was immediately started on oxygen via face mask. And she was, the picture was such that it shows significant carbon dioxide retention, poor oxygenation. And her oxygenation continued through NIV nebulizations. And other relevant investigations and physical examinations were done. And treatments included antibiotics, antipyretics, cough expectorants, and along with the oxygen in the ICU. So points to be discussed are how is palliative care helpful in this patient, and when can it be introduced to the patient? How can we improve this patient's acceptance to our health status? How to help the son to bear the responsibilities? And is there any way to reduce admission rate for this patient? I think we can open the discussions now, ma'am.
That's an excellent case. Thank you, Dr. Jyotsna. So any comments on, let's go question wise. So when do you, how do you feel about palliative care, and when would it be, when would you introduce it? And it's not just to Dr. Jyotsna, I'm asking it, it's open to all the people in the meeting. So when would you say that the treatment is warranted? Palliative care consultation is warranted? From the beginning of diagnosis of COPD, okay. Onset of disease during repeated admissions. Okay. That's a very interesting take on the consultation. Okay. So then the question arises that would you want as a, like, let's just say, like, we put ourselves into the patient's shoes and we have just been diagnosed with, let's say, COPD, as in this patient. Would you be willing to have a conversation about palliative care at that time? Would you be even accepting of the fact, and this is the time where you've not had a lot of symptoms, not even had repeated hospital admissions. So would a person be, kind of open to listening to the fact that it is a chronic disease, or it is palliative in nature?
Yeah.
So that is what, so this is what generally happens. Like, in theory, all the people would tell you ki, since the beginning of the disease you should involve palliative care, and it's sometimes not feasible, and it's sometimes like the patient would actually shout at you saying ki, what the hell are you talking about? I am not dying. Because that is a stigma that is associated with the word palliative, right? So, and not only amongst physicians, it's amongst everyone else. So it might be difficult to introduce it at the onset. If you had to introduce it at the onset, I think it would be feasible in patients who have a lot of physical symptoms for which you would need palliative care interventions. So, and for example, COPD, he presents to the hospital, or he's admitted to the hospital with severe breathlessness, and you introduce a palliative care consultant just to manage those symptoms. He would be more open to having her as her co-physician. I wouldn't say the primary physician, but a co-physician where he or she can just go in and, if automatically where, agar symptoms zyada hai, so he directly goes to the palliative care physician just so he can, or keeps in follow up with that. So that's where I would say that right at the onset, it would be feasible to have a palliative care consult. But as you rightly said, if the patient is having repeated admissions, so maybe not at the first admission or the second admission, but as you go down, you've had a lot of intervention, as in this case, she had to undergo multiple admissions, had to go undergo multiple investigations and a very invasive treatment, which irritated her. So that might be a good point to start a consult with the palliative care physicians. Okay. Some might be, as I said, some might be open to the discussion, but not all of them. Certainly more than 80% would not be willing to have that conversation. So chronic issue, yes, I agree. So the chronicity of the disease should be explained from the first visit. The need for palliative care physician can come in later. So once they understand the chronicity of the disease, then the subsequent talks or subsequent decisions are easier to make. Repeated admissions, yes. We can, so chronicity or the progression of the disease as it goes down. So since this one, like, so usually the exacerbations are because of infective etiology. Usually. So acute exacerbations of COPD are generally because of infection, for which they would generally be need to put on invasive, non-invasive or invasive ventilation for at least a couple of days, and they come off it and then they continue with the management and per se. So if the rate of admission increases, that is again a point where you can try to fit in a palliative care consults, like every other month she's getting admitted to the hospital. So another point where you can enter. At the earliest, yes, I agree that you should discuss it at the earliest as you can, but it should be within the framework of what I mean is that even if it's chronic, but if it is well managed with the ongoing disease modifying treatment that you're giving, sometimes the patient might not be willing to have those conversations with you and might just lose the trust that the patient has with you. So it depends. Like, kind of you have to assess how the patient is feeling and then go forward. So yes, so a better term to use would be a supportive management team. So you refer them to physio, you refer them to respiratory therapist, you refer them to so and so, like a psychologist also sometimes for counseling and all that. But it depends. So you kind of see what the patient or the relatives are open to and then go forward via that. Dr. Jaiswal, do you have a question? You can just unmute and ask.
Yeah, I want to add a point that in this is a classical case of an elderly patient having COPD. All of them go through the same phase. So we should check 3-4 points regarding the proper use of bronchodilator or not, proper uses of NIV in the home or not. As patient is in home care using CPAP, we should check some faulty techniques whether she is using it or not.
Yeah. Agreed.
And proper vaccination also.
Vaccinations as well. Yeah. So whichever, like influenza, maybe yearly influenza, because they are more susceptible to it. So vaccinations, wherever you feel that it would be of benefit, then vaccination should be given. I think Dr. Chaitra also asked the same question. Yeah.
Till what time can we treat acute exacerbation? Because there are multiple times. What indication is there to stop it?
That's an excellent question. So what do you feel would be the point where you don't give further treatment? So I recently had this conversation with my senior. This not per se about stopping the treatment. I was rather having a very detailed argument of sorts with my sir about advanced care directives in non-oncology patients. So when would you feel, or when do you decide that this is the point where the patient would have no further benefit? How would you decide that? That's an excellent question. Do you have any thoughts about that? Anyone has any thoughts about that?
Usually because those patients require higher antibiotics and ventilation. So hospitalization is a must in that case.
Yes.
So if there is financial issues with long-term medications and long-term NIV or oxygen support, then this also becomes a question for the patient and also the working person, caregiver who is with the patient.
Right. So one point becomes like financial issues. So if financially they are unable to sustain further treatment, that becomes a valid point where you say, okay, it's okay to stop it because the outcome won't anyways be so good that they will lead a near normal life. Let's just put it at that way. Okay, there are multi-organ failures, or there are poor prognostications per se. But how would you decide? Like, so what we're talking about here is that you're deciding that no further treatment is beneficial to the patient. So how would you decide that this is that final episode? It might not be. So because there's always a chance of the patient improving on those antibiotics, on that ventilatory support and everything. So how do you, but what point of disease trajectory? How would you decide that? So the disease trajectory is what is the main culprit, right? Because it is all up and down, up and down, up and down. So how do you, okay, one would be hampering your daily activities or deteriorating quality of life, but still you improve, right? Not near normal, but it is better than the ICU wala quality of life. So again, how do you see that it is okay to take the decision of non-escalation or withholding or withdrawing?
With family, maybe what they want, like what the patient wants, they will also have an idea how over the years how she's deteriorating, and maybe if she's like tired and enough, I don't want anything more, and family what's that, record it and then do the symptom care only.
Okay, so the first thing we saw was the financial issues. The second was care from the patient side or patient or the. I'm sorry, we couldn't hear you, sir. Yes, a discussion about the prognosis and the goals of care. So those are the three important things. So what after the discussions that I had with my HOD, so what we came to what we concluded rather was that I think it should be fair enough to say that we give a time limited trial to the patients. Time limited trial in the sense that we give all possible supportive care that the patient requires for 48 to 72 hours, depending on how much you want to keep it at. And still, despite giving everything that you can for the patient, he or she does not improve, then maybe say that this is like the terminal event, it's not improving on further treatment, and it would be better, and it would be it would lead to a poor quality of life, or it would lead to prolonged ICU stay, or prolonged care even outside the ICU. So that's what we thought would be an appropriate approach to these patients. Give them a time limited trial, see if they are improving. If they are improving, it's again have a discussion with the family members. Do you want to go ahead with it, or do you want to go on to a lesser aggressive measures? If not improving, then it becomes a bit clearer in the sense that the patient is not improving. The further care might just lead to a poorer quality of life. So again, also it leads to a better acceptance amongst the relatives also, because they are the ones who would be taking the decisions at that point. So it leads to better acceptance from the patient if he is conscious, aware. If not, then amongst the relatives as well. So always it's better to have that time limited trial as an option for patients. Okay, so that was about palliative care, when and how to integrate it. How can we improve this patient's acceptance of her health status? So one way of doing it is telling her about the chronic nature of the disease, is what I feel. And please pitch in if you feel that there is anything else that you want to add in. So the chronic nature of the disease. Plus, I'm sure somewhere she's aware that it has been deteriorating because of multiple hospitalization, because of her reduced activities of daily living and dependency. Though she's not completely agreeing with the fact that she is dependent, which is lead to her poor hygiene and as we said in the case. So, but she is somewhere, she knows that her health is not as it was before. So that is the way of doing it. Breaking bad news, again, with the help of counselors, if you are unable to do it for the patient. And sometimes it is better to have multiple sessions of counseling just to kind of prime her and then break the bad news also. So that would also help. Low dose morphine, yes, it does have a role, especially in this case, I would say, because this she was more worried about her symptoms rather than anything else, and she hated getting admitted or coming to the hospital in general. So a low dose morphine would have helped here, not only in reducing the breathlessness, but also with all the aches and fatigue that she was having, because it would have just helped her move around a bit more easily than she was at the moment. So morphine would have helped her. Steroids, again, if it was infective, then you don't want the infection to flare up more. So under the cover of antibiotics, steroids would have helped. But in case she was not willing for admission or for taking antibiotics, even oral antibiotics, then we need to weigh in the benefits and the cons of giving the steroids. But yes, steroids would in general help with the airway. How to help the son bear the responsibilities? So for improving the acceptance of the patient, I would suggest getting a counselor or a psychologist involved, just so that, or a volunteer if you have them in the institute where you work in. So what it does is that it basically helps us to kind of explore what their perception is, why are they so reluctant to accept that fact, and what are their worries and distresses, source of distresses. So if you kind of are aware about all those things, then getting her to accept the new reality or her new condition is easier. So that's how I would approach this patient particularly, because she seems like a person who is not very keen on opening up to the doctor, because she hates the fact of coming to the hospital, right? So maybe that's how I would approach her. How to help the son bear the responsibilities. The main reason was, one was the financial one, and one was lack of support from the lack of social support. So one way of doing it is that in case they have relatives to ask them to come in and help with the care of the mother, if it's possible. Sometimes it's not, but if it's possible. And the other way of doing it is asking the son to hire a caretaker, which might be difficult in this case because of financial issues, but he can just hire a help and tell his mother that because I'll be going for the job and you don't have anyone to look at, so I worry too much, so I'm hiring a caretaker for you. So that way the mother also kind of accepts the fact that someone will be there at home, because she was reluctant to have the caretaker particularly for her, so for herself rather. So kind of going about it in a different way would kind of make it acceptable for the mother to have, or rather the patient to have, a caretaker at home. Financial issues can also be addressed by helping them get funding from some resources, if it's available. So it depends on the social worker department and the hospital. If they have contacts, you can just give them an estimate about the cost estimate, and they can approach various agencies which give funding for even for supportive care. So that is one way of doing it. Government schemes, if that is feasible. Defining the goals of care from the son's perspective as well, and the patient, if she is willing to explore it. And then kind of formulating a plan about further action. Like, do they want to be at home, or do they want to be in an hospital, or in the hospital, do they want to be in the ward or in the ICU? So if you have a plan jotted down for all of this, then the cost in general would be addressed properly. Like, so it does not, you won't do anything unnecessary, right? So according to their plan, they don't want to shift to the ICU. So it's, if they are in the hospital, they would be in the ward. They would not be reshifted to the ICU. If they don't want to be in the hospital, they are at home. So the cost of care automatically comes down. So helping define the goals of care to help manage the further care. What to do and what not to do. When that is defined, it automatically helps not only the son, but also the mother to plan out what they want to do in general. Again, so to reduce admission rate, one would be, if the symptoms are well managed, with the help of, let's say, morphine here, the admission rates come down. Then if the patient is aware about the nature of the disease, and they have defined goals of care, that would again reduce the hospital admission rate. That is not to say that if the preferred place of care for them is the hospital, then there is no point in reducing the hospital care, but we can reduce the cost of care in the hospital. So maybe not escalating it to ICU care, just keeping them on supportive care in the ward would be fine. So it depends on what the preferences are. So it's always good to explore what the preferred place of care for the patient or the relative is. If it is the home, then it is the home. But if it is the hospital, where they are more comfortable because of the holistic care that is given in the hospital, then getting them admitted to the hospital is also a fair option. But again, you need to explore it with the relatives. Any other points that you have that you want to point in, or if I've missed out on anything?
No, ma'am. I think we've covered most of them.
Thank you.
Is there anything else anybody want to discuss? If anything wanted to, nothing want to discuss, shall we wind up the session, ma'am?
Yes.
Thank you, everyone. Thank you, ma'am, for a wonderful session. And please send in the queries, if any, to the group, and we will have it answered. So wish you all a good day and good evening. Thank you all.
Thank you. Thank you for the patience.
Thank you all. Thank you all for the participation.